have Dr. Hamid. Dr. Hamid has served in the Little Rock greater area community for 15 years, yay! So a little bit about her. She did her residency training in Pennsylvania, and then she did a fellowship in geriatric medicine and subsequently in endocrinology here in Little Rock at UAMS. She loved the city so much, fortunately, she decided to continue to practice here. And then she joined the Little Rock Diagnostic Clinic, now CHI, of course, in 2008. She loves taking care of all components of endocrine care, and to that end, she's going to talk to us a little bit different now about osteoporosis.
Thank you so much. Thanks. I would like to thank the organizer to invite me for this talk, and I would like to thank the audience to spend their weekends with us. So my topic would be osteoporosis. I have prepared two cases that we see not uncommonly in our clinic. I will go over the case and then the management depending upon time permits. So my first case is Ms. Jones. She's a 60-year-old female who was babysitting her grandchild. She went down to pick up her grandchild and she developed sudden back pain. She thought that she pulled up her muscles and she started taking some analgesic over the counter. Her pain got worse, that she was unable to sit, and she presented 3 days later to her physician, who ordered an x-ray of her spine. And as you can see, she has a compression fracture of her vertebrae here. What about her history? She had a hysterectomy and bilateral hysterectomy when she was only 35 years of age due to endometriosis and cyst in her ovaries. She was started on hormone replacement treatment, however, she developed DVT, and therefore her HRT had to be discontinued. She doesn't like dairy product that much. She tries to use some calcium, vitamin D. She tries to walk about 1 mile a couple of times per week. Prior to her presentation 2 months ago, she had a bone density done by her family physician, and this is her bone density. So her T-score at her right femur, completely normal. Her T-score at her left femur, completely normal. And her T-score at lumbar spine 2 months ago was completely normal. So the question is, does she have osteoporosis? So in 2020, ACE came up with the guidelines for the diagnosis and management of osteoporosis, and these are the definition of osteoporosis. So anyone who had a bone density with a T-score of minus 2.5 or below at the lumbar spine, femoral neck, or the radius, they are considered osteoporotic. Low trauma fracture. So regardless of bone density, whether it's normal or abnormal, anyone who has lumbar spine or hip fracture, they have clinical diagnosis of osteoporosis, irrespective of their bone density. Anyone who has osteopenia, which is T-score between -1 and -2.5, and a fragility fracture of humerus, pelvis, or distal forearm, they are considered osteoporotic. And then anyone who has osteopenia, but high FRAC score, they are considered osteoporotic. And the fragility fractures are the ones that are defined by a degree of trauma that you would not expect to have a fracture. So in Ms. Jones' case, she just went down, she tries to pick up her grandchild, she developed fracture, that's considered a fragility fracture. Be mindful that toes, fingers, skulls, and ribs do not count. So if you have a patient who had a coughing bout, came to you, told you, Doc, I fractured my rib, does she have osteoporosis? The answer is no. So those are the bones that are excluded for the diagnosis of osteoporosis. So who should get the bone density? We sometimes often neglect to take care of our patient's bone health because we're too busy taking care of multiple other acute medical problems. So when we see women in our clinic who are above the age of 65, and I would emphasize men above the age of 70 because we tend to neglect our men more than our women, they should get bone density to evaluate their bone health. Postmenopausal women, if they are above the age of 50 and they have adult onset fractures. So if somebody broke their elbow when they were teens, that doesn't count. But if somebody has an ankle fracture in their adult life, they should get evaluation by bone density. Postmenopausal women and the men between the age of 50 and 70, depending upon their risk profile, they should have a bone density. This is a busy slide. There are so many risk factors, and they're included in the syllabus. But just wanted to highlight a few points here. When we see frail patients who are frequent fallers, it's important that we get the bone density, treat them early on so we prevent a hip fracture or a lumbar fracture and disability or nursing home on those individuals. Somebody who is premature menopause, in our case, Ms. Jones had a hysterectomy and oophorectomy done at the age of 35, so she had a pretty early menopause. She could not use HRT, so those individuals should get bone density. Nowadays, we are seeing more and more bariatric and gastric bypass surgeries, and those patients tend to lose bone very fast, and those should be evaluated for their bone health. Patients who have congestive heart failure, diabetes, stroke, they are at increased risk of falls, and their bone health should be evaluated. We have to be mindful of the medications that our patients are using, and glucocorticoid, we all know when patients are on steroid for more than 3 months, they tend to lose bone. We are seeing a lot of aromatase inhibitors, a lot of women with breast cancer on anastrozole, letrozole, those therapies, they tend to lose their bone very fast. A lot of men are being treated for androgen deprivation therapy for their prostate cancer. We tend to overlook those individuals, so they should get the bone density. Immunosuppressive treatment, proton pump inhibitor, lots of Nexium, pantoprazole, those medications are being used by our patients a lot, and they're associated with bone loss, so we have to be mindful for that. And women who are using, or men who are using thyroid hormone in excessive amounts, so their TSHs are low for a long period of time or suppressed, they should get evaluation for their bones. These are the medications that are associated with increased risk of fracture, and if you pay attention to that, most of these are medications that would cause increased risk of falls. So if you have somebody who is on insulin, opioids, benzodiazepine, these drugs, broadly, patient tends to fall, so we, just mindful that we need to evaluate their bone health. Once you have a bone density, how do you interpret the results? So the T-score of -2.5 and below are considered osteoporotic. -1.5, -1 and -2.5 are osteopenia, and -1 and higher is normal. And just wanted to highlight one thing here. So what is T-score? The T-score is basically a difference of standard deviation between a bone density of your patient and an average healthy bone density of a 30-year-old person of the same sex and same ethnicity. And I wanted to highlight this point because a petite person, when it's being compared with a healthy 30-year-old person, that person will be looking abnormal. So when you are interpreting bone density for your patients, be mindful that if they are of a petite stature, their bone density will be looking falsely low. So we have to use our clinical judgment when we are trying to treat those individuals because they may not be as low as they look on the bone density. The Z-scores are the comparison for the women or men of their same age, sex, and ethnicity. And when do we use the Z-score? So the Z-scores are being used for premenopausal women or men in the younger age group. So we cannot use T-score if women are not postmenopausal or men of a younger age, which is below 50 and in some cases below 40 for the men. So a lot of time we see in our practice, patients comes with a bone density and there is no mention of Z-score when they are premenopausal. Well, you cannot interpret that bone density. So it has to be repeated, and the Z-score has to be taken into consideration when interpreting those in premenopausal women or younger men. After the diagnosis of osteoporosis is made, it is important that we do some basic evaluation to rule out any secondary causes which can be treated or cured. So these are the basic labs. We usually obtain them in our clinic on a regular basis anyway. So CBC, vitamin D, PTH, CMP, liver function test, testosterone in men if you are suspecting hypogonadism. Don't routinely have to do those. There are some other tests that can be performed. So if you're suspecting celiac disease, which increases the risk of osteoporosis, Cushing's disease, if myeloma is suspected, then those additional tests can be ordered. So we established the diagnosis of osteoporosis on our Miss Jones because she had a fragility fracture, although her bone density was normal. So how should we treat her then? So before we start treatment, thankfully these days, besides bisphosphonate, we have other classes of medicines that are available. So luckily we have more choices, not as many as we have for diabetes nowadays, but still we have some choices to choose from. And what drug are we going to choose first? And in order for us to find that out, we have to do risk stratifications on our patients: high risk, moderate risk, low risk. So individuals who have osteoporosis is considered very high risk when they have any of those. One is if they have a fracture within 12 months, if they have multiple fractures, if they have fracture while they are on treatment, so they are taking a Fosamax and they have a fracture, they're considered very high risk. If they have a fracture while they're on medicines like glucocorticoid, in women, anastrozole, if their T-score is very low, so if it is below -3, that's considered very high risk. And if their FRAC score is greater than 30% for major osteoporotic fracture and greater than 4.5% for hip fracture, so those individuals will be considered very high risk. So the risk of breaking bone in the next 12 months are pretty high. The high-risk individuals are the ones who had prior fracture before 12 months. If their T-score is -2.5, which is the definition of osteoporosis, or if their T-score is in osteopenic range, but their FRAC score is elevated greater than 20% for major osteoporotic fracture and greater than 3% for hip fracture. And the low risks are they don't have any fracture, their P-scores or their bone densities are normal, or their FRAC scores are low, less than 20% for major osteoporotic fracture, and less than 3% for hip fracture. So, patients who are very high risk, the preferred agents are anabolic agents, and the anabolic agents are the ones that help with the formation of the bone and decrease the resorption of the bone. Up till now, we had mostly medicines that would help with the resorption. Luckily, we have these medicines which not only decrease the resorption, but they improve the formation of the bone. And those are romosozumab or parathyroid hormone analog, which is teriparatide or abelopeptide. If patients are not able to use that for a variety of reasons, when we'll come to that, the other alternative that they can use is denosumab or bisphosphonate, and the preferred bisphosphonate is either alendronate, which is Fosamax, or zoledronic acid. In the high-risk patients, the preferred drug is denosumab and bisphosphonate, and the other alternative is bisphosphonate, but the abendronate and raloxifene are the alternative. The preferred bisphosphonate is still alendronate, zoledronic acid, or acidronate. So, Ms. Jones had fracture, and therefore she is a very high-risk patient, and we discovered that the anabolic agent is the one that is going to help her the most. So the preferred agent for her would be romosozumab. So what is romosozumab? It is the sclerostin inhibitor, and the sclerostin is the cytokine that gets released from the osteocytes. So in our bone, we have osteocytes, then we have osteoclast, and then we have osteoclast. When sclerostin is active, it causes the inhibition of osteoblasts, which are our bone-forming cells. So when our bone-forming cells are inhibited, there are more activation of the osteoclast, and it causes more bone resorption, weakening of the bones, and thus the fracture. So on the second side here, I can't get my point over it. So the romosozumab binds with this sclerostin, and therefore it causes more formation of the bones, cells, osteoblast, decrease the formation of osteoclast, and it has dual effect. So it increased the bone formation and decreased the bone resorption. The FRAME trial that studied the medicines, so romosozumab, which is Evanity, and they had patients placebo and the romosozumab for 12 months, and after that, both groups started receiving denosumab for an additional 12 months, so a total of 2 years of study, and they had found that patients who were on romosozumab, they had a 73% reduction of vertebral fracture, and even though they used denosumab after 12 months, the fracture reduction persists in people who have used Evanity, 75% lower risk of vertebral fracture as opposed to people who have used denosumab only. So major risk reduction in the vertebral fracture. So this drug is administered every month in the clinic by the provider, and it is only for 12 months, because after 12 months, the effect of drug was waning on the bone, so there was no advantage of using the drugs beyond 12 months. And once the drug is being discontinued, the gain of the bone density is going to be lost. And therefore, it is very important, after the drug is being discontinued, that it is being overlapped by an anti-resorptive treatment to preserve the effect of this, otherwise the patient has wasted 12 months of injections. So in Ms. Jones' case, since it was a preferred drug, anabolic agent, we decided that she should be a good candidate for this drug. However, on further questioning, Ms. Jones indicated that she had chest pain 6 months ago, and she had a stent placed in for her coronary artery disease. So should we give her this drug? And the answer is no. And why is that so? So in the clinical studies, there was increased risk of cardiovascular disease with the use of this drug, and therefore it is not indicated in someone who had a stroke or any cardiovascular event in a past year. Now, it's not absolutely contraindicated to anybody who had a cardiovascular disease. It's only if they have a cardiovascular disease within 12 months. And use it with caution, and make sure you make your patients aware that there are studies that suggest that, but beyond 12 months or a previous year, this drug can be used if a physician felt that it is important for the patients to use it. So unfortunately, Ms. Jones is not a candidate for this treatment, so where do we go next then? So the other anabolic agents that we have available now is abaloparatide, which is Tymlos, which works on a PTH-RP. It's an analog, and it causes the remodeling of the bone in favor of bone formation. So again, patients have increase in their bone density with this medicine. It is used as sub-Q injections every day, and its treatment duration should not exceed 24 months. So it's only indicated for 2 years in a patient's lifetime as of now. The other one is teriparatide, which is for tail. It's also available in generic form nowadays, and it is a PTH hormone fragment 1-34. It is used as 20 microgram injection every day. It was also restricted for 24 months, but nowadays there are some studies that suggest that it can be used beyond 24 months in patients who are high risk, or they turn into high risk later on. So it's not limited to the lifetime of patient for 2 years. There are some studies suggest that it can be used after that as well. So Ms. Jones would be a good candidate for either one of those treatments. Regarding the Tymlos, there was a study published in which they have assigned women to the abaloparatide, teriparatide, and the placebo, and they have found that significant reduction in non-vertebral fracture between the placebo and Tymlos, about 86%. Non-vertebral fractures 43% reduction. This was a study that compares the abitropeptide, teriparatide, and placebo, and as you can see in the purple and blue, those individuals gain a lot of bone, which is expected because it helps with the bone formation compared to the placebo. Similarly, for the total hip, the middle slide, and the last one, the femoral neck, both teriparatide and abitropeptide causes the bone gain as opposed to the placebo group. This study was not designed to compare head-to-head teriparatide and abitropeptide, so we cannot make that one drug is superior to the other. It's just this drug was not powered enough to identify those differences. But both of these anabolic agents causes significant improvement in the bone density at the lumbar spine, hip, and the femoral neck. Before prescribing this drug, obviously it's important that we all rule out the contraindication and caution in our patients. So in the rat model, where this drug was used in a very high quantity, there was increased risk of osteosarcoma, and that's a black box warning for this drug. Therefore, any individual that seems to be at a higher risk of developing osteosarcoma, patients who have Paget's disease, patients who have bone metastases, or if they have a skeleton radiation, should not be using this drug. If someone has hypercalcemia or unresolved hyperparathyroidism, so if you have a hyperparathyroidism patient, they had a parathyroid surgery, they are cured, this drug can be used, but if they have unresolved hyperparathyroidism, since it increases the risk of elevation of the calcium, should not be used on those individuals. Unexplained alkaline phosphatase, which suggests the Paget's disease, should not be used. Any skeletal malignancy should not be used. And if somebody has active kidney stones, since it increases the calcium excretion, use it with caution. And again, all the anabolic agents, once you stop those medicines, you lose the anabolic effect. The bone density starts declining rapidly. So if you're using these drugs, make sure your patients are candidates for anti-resorptive therapy and you have to start them immediately. Otherwise, the effect of drug will be lost. So, Ms. Jones was a good candidate, however, she said, there's no way I can give myself an injection. So, this option is out for her. So, other alternative now we have is denosumab, which was in our preferred list of the drugs that we can use in a very high-risk individual. And denosumab is not an anabolic agent, it's an anti-resorptive agent. And the way it works is that it inhibits the rank ligand binding to the pro-osteoclast. So the rank ligand, those purple circles that you all see, these are the cytokines that gets expressed on the osteoblast cells, which are the bone-forming cells, and the lymphocyte cells. And when those rank ligands bind to the pro-osteoclast, they causes the maturation of the osteoclast cells. And when you have more osteoclast, you lose more bones. And the denosumab inhibits the binding of the rank ligand to the receptor, and thus it causes decreased maturation of the osteoclast, less bone resorption, and less risk of fracture. In a freedom trial, that was a trial that was conducted in postmenopausal women, and they have a placebo group and denosumab for 3 years. And if you look at it, there was a 68% reduction in a vertebral fracture, 40% reduction in a hip fracture, and about 20% reduction in non-vertebral fracture in women who were prescribed denosumab treatment. Regarding the bone density improvement, 6.4% difference in the bone density at hip, 8.8% difference in the bone density spine, and 5.2% increase in the bone density in the femur, which is pretty significant. So the option that was left for Ms. Jones is to try denosumab every 6 months, and it's given every 6 months. So now Ms. Jones is 65 years of age, and her insurance is changing, and she chose Medicare Advantage plan, which does not cover her denosumab. So what should we do now? So she has been on treatment for 5 years, she's tolerating it well, she did not have any fracture, and that leads us to an important topic that we all struggle as an endocrinologist or as a physician. What do we do? So my next topic would be drug holiday. Why do we think about drug holiday? So whenever we talk to our patient about the bone medicine, first thing they said, my jaw hurt, my teeth hurt, I'm having my teeth pulled, my friend had a teeth pulled and she never heals. So patients are very fearful for this condition. And it is called osteonecrosis of the jaw. And there's a picture for that. And what is actually osteonecrosis of the jaw? It's a non-healing wound in the oral mucosa with exposed bone that lasts for greater than 8 weeks. The incidence of osteonecrosis of the jaw in osteoporotic patients is only 0.001% to 0.01%. It is very, very, very small. And mostly it is seen in individuals who are using very high risk of these treatments. A lot of cancer patients are using denosumab every month for their bone metastases or so. Those patients are mostly at a higher risk of developing it as opposed to the osteoporotic fracture. And people who are using long-term oral bisphosphonate, the risk is only 0.21%. And it is mostly associated with tooth extraction, and the risk is so small that American Dental Association does not recommend stopping bisphosphonate for dental procedure. In the past, it was difficult to find a dentist who would pull a teeth of a patient when they were on a bisphosphonate, and that's the most complaint that you would hear. But the American Dental Association come up with the guidelines, and they are not even recommending the patient stopping the bisphosphonate. If the tooth extraction is planned and you are about to start the patient on a medicine and they are having major surgery performed on their teeth or so, it's not unreasonable to wait for a few months, but it's not a contraindication. The American Association of Oral and Maxillofacial Surgeon, they recommend that if patients are on bisphosphonate for more than 4 years, to stop the medicine or give a drug holiday for 2 months before they have an intervention. And routine dental care can prevent the ONJ. So the next fear that we have when we consider drug holiday in our patient is atypical fracture of the femur. And this is usually the fracture of the femoral sheath. It was first noted in 2007. It is usually associated with prolonged use of bisphosphonate, but it can be seen in denosumab and romosozumab. Usually patient presents with the pain in the thigh or the groin, and the pathogenesis is unclear. There has been some theory that we are inhibiting the bone for a long period of time, resulting in that, but right now we don't completely understand the pathogenesis of that. The incidence of atypical fracture, again, is very, very low. So there was a study done in California in their big health organization where there were about 1.8 million patients. And the risk of atypical fracture was 3 per 100,000 years when the bisphosphonate was used for 2 years, 20 per 100,000 years when the bisphosphonate used for 5 years, and 50 per 100,000 years when the bisphosphonate used for 8 years. However, you can prevent about 100 fracture by only treating 1,000 patients. So do your math. And then you can prevent 11 hip fracture. So the risk of atypical fracture, again, is about 0.1%. And if we share those statistics with our patient, hopefully we can convince them that this is not as dangerous of a drug as they think about it. The risk of atypical fracture goes up as the bisphosphonate is being used. So if it is used for less than 3 years, atypical fracture is only 5.6%. If it is used less than 5 years, it's only 2.5. Less than 8 years, 6, and if it is used greater than 8 years, the incidence goes up to 13.1. So it is connected to the duration of the bisphosphonate use. There is a huge variation in the ethnicity. So the Asians sees more atypical fracture, 6. Black has the lowest atypical fracture of 0.2, and Hispanic and white similar. And this is a very good slide if we can convince our patient. And this is the slide that shows that in the red line, the number of clinical hip fracture prevented by the use of medicine. The blue line is the number of hip fracture prevented, and the purple line is the number of atypical fracture. So the purple line is at the very bottom. So if you look at the 5-year mark, for the white women, which is B column, you are preventing about 859 clinical fracture, 286 hip fracture at the cost of only 8 atypical fracture. So again, it's emphasized that yes, those are very dangerous side effects that patients believe, but the incidence of those are very, very small. So the question is, should Ms. Jones be given a drug holiday? She's been on treatment for 5 years, and the answer is no, because denosumab, when it stopped, the bone density decreased 6.6% in the lumbar spine, 5.3% in the total femur within the first 12 months of discontinuation of the treatment. So the effect of denosumab wears off pretty fast, and the bone density declines pretty fast. There is an increased risk of multiple, not one, multiple vertebral compression fracture of about 5%. And the vertebral compression fracture was reported as early as 7 months. So if your patient was due in 6 months for denosumab and you skip 1 month, the risk of fracture goes up. This cartoon shows that denosumab improved the lumbar spine bone density, which is in a blue, pretty fast. And as the drug is stopped in that gray area, you lose the effect pretty fast, within 24 months. And the CTX is a bone resorption marker, and the bone resorption markers goes up pretty fast after the medicine is stopped. So the drug holiday is only specific to bisphosphonate, Fosamax, zoledronic acid. So what is drug holiday? Drug holiday is a temporary discontinuation of the drug for up to 5 years, but it can be extended depending upon your patient's risk factor and clinical characteristics. If the drug is being stopped, make sure we assess our patients every 2 to 4 years. And if they develop fracture, if their bone densities are declining, or they are developing any risk factor, the drug should be started back again. The risk of atypical fractures start reducing or going down. So the first 3 months after you stop the bisphosphonate, the incidence rate is 4.5, and after 48 months, the incidence of atypical fracture goes down to 0.5. So who should be given drug holiday? Patients who are at moderate risk of fracture if their T-score is above 2.5 and they do not have any recent fracture. So they can be given drug holiday after 3 years of zoledronic acid and after 5 years of oral bisphosphonate. If patients are still having high risk, so their T-scores are still below 2.5, they had a fracture, or they are using a medicines that increases the risk, they should be given oral bisphosphonate for 10 years and the zoledronic acid IV for 6 years before the drug holiday is considered. Patients on denosumab reassess their risk in 5 to 10 years, and if their risk factors is low, make sure we convert them to a different agent before giving a drug holiday. So do not start denosumab without overlapping it with other agent, which is usually the oral bisphosphonate or zoledronic acid. So this is a slide that just summarizes what I have said, reassessing the risk. If the patients are still at the risk of osteoporosis, their T-score is still low, they should be continued on a longer duration of the treatment. But if they are considered as a low risk, they should be stopped. I don't think I have a time for my second case, so that will be for next year, Dr. Lau. Thank you so much for your attention, and if you have any questions.